Hello, everybody, and welcome to our lecture about the hips and about bony structure of the hips. I split pelvis and the hips on purpose because I thought, it will be a little bit easier to process. But at the same time, pelvis and hips, obviously, they work together as a kind of as a unit, and the one movement affects the movement of the other one. All right. So let's get started. Our learning outcomes for today are quite simple. We will define the structural components of the hip complex and we will explain their roles, what they do, why do we need to know that, how can we make them better, or do we need to worry about that in this lecture. So let's get started with the hip joint. Here you can see the left side of the hip joint, and it's an anterior view, meaning I'm looking from the front. Here you can see the whole pelvis, and you're looking from the front anteriorly. And let's look at this picture on the right side, right? This is like a hemisphere of your pelvis. The top part is ilium. Now you can see your sitting bones. This is the pubis, and there's a pubic symphysis attached to that, and there's a sacrum behind that's not visible in this particular photo. And then you have parts of the hip joint, and then you have acetabulum, which is your hip socket, and then you have a labrum, which is this blue part that you can see. Then you have femoral head, that's this blue kind of circle here, and then you have a femur. This part is femoral neck. We're not going to we touch on a little bit on it, but I just didn't split it from the femur itself. And then this is the femur, which looks like a dog bone, essentially long, strong bone. And the greater trochanter is kind of this part sticking out, which you can easily palpate. So if you stand up and palpate, this is where your hips are, right here, right? And if you kind of shift, let me just move. If you shift side to side and place your hands on the side of your hips, as you shift, you will notice that's kind of where you feel the bone, right? Translating, that's your greater trochanter. All right. Now, starting with the acetabulum, since it's the first one in the list, you can see there's like sockets here, right? So your femoral head is kind of goes inside the socket. So acetabulum literally means the little vinegar cap in Latin, and it's just really beautifully describes what this socket does. It's a concave container, like a cup, that designs to receive something and distribute it around. In the case of the hip, that's force, that's load, that's compression. But what's often is not talked about, or at least I didn't see a lot of this discussed around anywhere, is that acetabulum is not uniformly load bearing, meaning that it doesn't design to carry the load evenly across its socket, like across inside, right? The articular cartilage forms a horseshoe shape, and the central acetabula fossa, actually the one that is like deep inside, it doesn't really bear a lot of compressive load. And that means that it means that the hip is designed to distribute compression and load around the rim, not centrally, right? So most of the load happens here, not deep inside. And that's important because degenerative changes often occur in the rim itself. They don't occur deep in the acetabulum. And particularly when morphology creates with the repetitive movement, repetitive contact, right? So you can hear about labrum tears and all this kind of thing. So that's the outside rim. And another important detail probably is that acetabulum faces laterally, means it's on the side, it's inferior, slightly lower, and it's also a bit anterior to the front. And that explains why most of us are really good with hip flexion, but the hip extension, you usually don't see a lot of range just because of the position of acetabulum. And saying this is, we are also different in that position, right? It varies slightly from human to human. So some people will be better with internal rotation, external rotation, or external rotation. Some will be better with hip flexion and external rotation, and some will be better with hip flexion and internal rotation. And that is because we have all different kind of positioning of this sockets and acetabulum of the acetabulum, right? So it can be slightly more turned in, slightly more turned out, slightly more inferior, slightly less, and so on, right? So it really depends. I have a cool slide in the very end to show that. Okay, so sometimes why do you need to even think about it? Like, why does it matter, right? I'm always like, but what's in it for me? Like, why does it matter? It's because when your client runs out of range suddenly, you kind of think, oh, maybe it's the muscle hip flexors are tight, right? So that's why they can't hip extend. I need to stretch or I need to do like something, right? But sometimes it's the case, but sometimes it's not. It can also be that they are just geometrically, like they can't do it. It's just their geometry, right? The socket is a little bit forward. That's it. So acetabulum is not, it's not just like, think about it, it's not just the hip socket, it's also something that defines our movement, our direction of movements. It's like a directional structure. All right, moving on to the labrum. And this is the labrum, this blue one, as you can see. And the labrum deepens the acetabulum roughly by 20-30%. Now, we're like, oh, it doesn't make any sense, right? So if it doesn't make any sense, I have a cool analogy for you. So imagine you have quite like a shallow plate, right? You have a shallow plate, and then you have an apple and it sits inside the plate. And then to deepen the plate, you put the silicone that kind of is on the plate, but it also covers the rims of the plate, right? So it suddenly got a little bit deeper. If you're like, what? So think about it this way. So you have an apple dish, right? That round dish with rims up, and then they kind of open, and then you put your door, and then the door kind of comes up and over. So we suddenly made it a bit deeper, right? Because it's a little bit more over, and you can make it a bit thicker in terms of the rims make a bit thicker using the door, right? So that's kind of similar how it works. So I hope it makes sense to you. If it doesn't, let me know, and I will make sure like I'll record something else to explain. Anyway, it does more than increasing depth for 20-30%, but it also creates a suction seal, right? So it really holds that, so that like it really holds the femur head inside. So that negative intra-articular pressure, that's what it's called, increases joint stability without you engaging any muscles. Yeah. So just when you stand up, this happens without you squeezing anything or moving even, right? Well, just when you stand up. So historically, we thought about labrum just like as a padding, and then sometimes it wears and tears as you age, and it's kind of how it was. But modern research uh, understands that it plays quite an important role in joint pressurization and fluid and synovial fluid dynamics, because inside any moving joint, not only the hip, there is synovial fluid. So if your joint is mobile, there is fluid in it, in your body, right? So there's synovial fluid that helps to lubricate. If your joint is still, for example, like sacrum in between your iliac joints, that's designed to be relatively still, very, very little movement. There's cartilage there. But in the joints like hips, there's a synovial joint there. So this joint helps to maintain the synovial fluid distribution under the load. So when the labrum is compromised, when there is like any injury to it, like a tear, for example, the joint stability can decrease. But it's not because the joint become loose itself, but it's more because the fluid seal is a little bit altered. However, this labral tear may feel, individuals who have it may feel that it's quite unstable. The joint is unstable itself, but the ligaments may all be intact. And saying this, it's important to probably acknowledge that you may have a labral tear, but you may experience absolutely no symptoms. You can be asymptomatic. So not every labral tear is the same. So again, structure doesn't equal pain. Yeah. So we probably know that by now. But mechanically, the labrum obviously matters to the movement. So it enhances that congruency of the joint and stabilizes pressure, but doesn't really increase without increasing any tension. All right, so moving on to femoral head. This is like this round kind of bit of your femur. it's almost round, right? It's not exactly kind of exactly like a ball size. You can see like it attaches to the neck. It's not perfect sphere basically. And it also the cartilage around it, because it's covered like this blue thing is a cartilage, is thicker superiorly on top, and it's thicker where the compressive load is the most. It's coming from the ground force up, so that's where it's thicker. So it's not really random that it's thick there, because when you stand, that the most load comes into that part of the, like if you just visualize it, right, the most load comes into superior part of the femoral head, and that's where the cartilage is thicker. But the head itself covered pretty much entirely in this cartilage, which is called hyaline cartilage. um, Maybe except for some parts where the ligament attaches, it is just really really deep in the hip joint. This ligament called ligamentum teres, and it attaches deep in the hip joint. Sometimes on the cross sections you will see it. We'll go through it a bit later, and that's where there is no cartilage basically. But there is something quite interesting. The head, the femoral head, receives its blood supply from the medial femoral circumflex artery. Don't worry if you're like, what? It's just the artery that supplies it's just the artery that supplies the blood to the femur head. The important thing, and that's something for us to notice, that the disruption of this supply, such as, for example, femoral neck fracture, which you may heard of, right? There can be femoral neck fractures, and usually that's you go to hip replacement if you had this. It's a pretty strong structure, so to have femoral neck fracture, it should be an accident. It doesn't fracture by itself, so it should be a serious accident. Anyway, so the disruption of this supply, like in the when what for example that happens in the fracture, can lead to what's called a vascular necrosis. And it just, in simple terms, it means that it's a death of a bone tissue due to the lack of supply, and it often leads to tiny breaks and eventual collapse of the bone. And it doesn't only affect the femur head, it affects the knee, it affects the shoulder, causes a lot of pain, limits a lot of range, and can lead to severe arthritis. And we are talking about really painful arthritis. And usually, these clients, patients, they will go through replacement of the joint. And this is also one of the reasons why the hip fractures in older adults are such serious injuries. Because, so what happens with, yes, you can replace, but the older you get, the even if you can replace the hip, so for example you're 84, let's say, or 80 years old, right, and you have this like hip pain and you fell, they can replace the bone, but will you survive a surgery? They will have to assess you. Will your heart survive the surgery? That's one thing. And the second thing is that how will you recover? What if you get an infection? What if you fall again? Because you will be weak after the surgery, right? So all these things are considered, and not every client will undergo through hip replacements. And that's why when you work with older population, it's important to understand that, and it's important to focus on their sit to stand, to prevent the for routine that prevents the falls. Maybe a little bit less about being really strict with their alignment, or like abdominal, like, or focusing on abdominals. It's all important, but here you are making your critical decisions, right? So when you're teaching older populations, for many of them, not for everybody, but for many of them, the strong focus must be on preventing falls, sit to stand so they don't fall, because not always they can have a replacement of the joint due to the age and due to heart and what other kind of, as we age, we have a lot of health complications. So yeah, all these are important to consider. Okay, so as just to summarize, that the femoral head is built to tolerate compression really well, but it doesn't tolerate shear. This is something that's called cam morphology, and cam morphology is basically an inflammation of like around the neck of the femur, and it increases shear during flexion and rotation, and it's kind of much more concerning and painful to individuals than just pure compression. The femoral head itself loves compression. It doesn't love that kind of repetitive, abnormal translation. We will go through camshair in this lecture in a bit. So I just zoomed through it. Okay, so moving on to the femur. It's the longest and the strongest bone in the body. If you ever watched, I should have included the link here, but if you just Google hip replacement, if you ever watch it, it is an absolutely fascinating procedure. How strong the bone is when they replace the hip. They usually replace the kind of labrum, and then they replace the femoral head and the femoral neck. And to get the femoral head and the femoral neck, because it's of like metal, titanium, whatever they metal, whatever material they use, to get this part here into this part, the femur, they use the hammer to kind of hammer it in. It's like a long kind of like a long, not a needle baby, but like a spike going kind of almost halfway to the femur. And the surgeon is like a construction worker hammering it in. So it's not an easy kind of plug it and forget it. It's quite a strong bone, quite a strong structure. So we kind of know that the neck shaft angle, this guy here, is typically around 125 degrees in adults. That allows us to stay upright. That allows us to stay upright because the femoral neck and femoral head, graded trochanter, will position above the knee, right in the center of mass, so we can balance, right? So we don't, so it's not too wide out, it's not too much in, so we're not going to fall. However, this angle is different in other people, and if it's a little bit more, then the adductor leverage decreases, right? So it's a little bit more, so the adductor will become a little bit weaker, and if it's a little bit less, then the compression of the hip increases and abductor leverage improves. So probably of this, what I would summarize and would say, okay, this is something that you need to remember from this lecture, right? Is that our geometry is different from human to human. So what you expect from a person in the studio should be realistic to how they're built, right? And obviously, you sometimes don't see it with the naked eye, but sometimes you're like, okay, maybe it's not a tight muscle. Like I've been working, it doesn't go anywhere. Maybe it's just the position of the hip, the acetabulum. Okay, so there's another variation that we have different in between us as humans is the what's called femoral version. Version means just rotation of the bone, right? So just how this bone is rotated, and it just means there is like normal anteversion and high anteversion and low anteversion. So normal anteversion, ante means Latin, means forward. So it means forward rotation and inward twist, right? So forward rotation and inward twist here. And it ranges around 10 to 20 degrees between individuals. It's quite a big number. High anteversion increases apparent internal rotation and reduces external rotation, right? So in high anteversion, my femur will be a bit more forward. My legs will be a bit more forward, right? Sitting in the acetabulum. And in low anteversion, or it's called retroversion in some other literature, it just means the opposite. It will sit a little bit wider. So it will increase external rotation, right? So why is this important? Because this will affect how the person is presented in stance, in gait, in a squat. Before even you think about the muscles, there are bones that kind of define the range or define how movement will look. So femur is a lever. Its length amplifies torque, but also amplifies joint reaction forces, right? So you probably, the best example here would be in your hundreds. If you straighten your legs, it's hard. If you bend your knees, it's easier. So this is obviously there's a lower leg as well involved. That makes sense. But there's also femur, right? It's a strong bone, it's a long bone. So if you increase it, you increase the lever onto onto your pelvis, right? So your pelvis have to bear much more load. All right, we're moving on to greater trochanter, which is this part, and it's essentially a pulley system. It's basically increases the moment arm, and the moment arm is the same as a lever. Increases the lever or the moment arm of the gluteus medius and the gluteus minimus. So you can't see it, but if you look posteriorly, that will be attached to the ilium, yeah, and kind of will go through to towards the femur. So without the graded trochanter, those muscles will have much less mechanical advantage. So its position laterally, right, to the side is quite important. So the further your greater trochanter is from the hip center, the greater the abductor moment arm or lever, right? So it makes sense, right? So the further you go away, the longer the greater that lever of the abduction, and it affects how much force abductors must produce during, like, for example, single leg stance, right? So in the condition what's called coxa valga, and coxa valga is when that hip kind of neck angle decreases, right? Remember, it's an average of 125 degrees, and then when it increases, the trochanter sits relatively closer to the hip center, right? So it's a little bit closer to the front, and it just decreases the leverage of the abductor. So when someone struggles with single leg control, the question for you to think about is it neuromuscular, or maybe it's the structure, the geometry, maybe it's the leverage, right? So it's maybe it's just something, mm, something that with the angle of the greater trochanter, for example, it's not the greater trochanter is not just the bony bump that you have kind of to palpate. Yeah. All right. Before discussing control or stability, we need to understand that hip is primarily a geometric kind of structure, and muscles don't create their range from nowhere. They work within the boundaries that are already set by bone orientation, by joint depth, and by version, by these angles that we discussed in the previous slide. So before muscle contracts, or before you decide in the class what cue to give, before someone activates their glutes, as you make you, for example, the architecture of the joint has already defined some important things. For example, like how much range is available to the individual, where compression will be distributed and where compression occurs, where the tension will appear, which direction will feel easy and more natural, and which directions will feel the opposite, kind of like blocked or restricted. So muscles do not create the space inside a joint themselves. They just move the bones within the space that already is predefined, that already exists. So I'm running ahead of the train here, but we'll go in more details in a bit. So if acetabulum faces more anteriorly, right, internal rotation will appear quite generous, um, and extension will feel the opposite, will feel restricted. And as much as you can and want strengthen, it won't change it won't change the socket orientation, right? So yes, muscles are helpful, they're great, like you have to, we work with muscles, that's exactly what we need to do, but we need to respect that there is a, there's bone structures before the muscles. So if, for example, femoral anteversion is high, anteversion, I'll just remind you, is a little bit slightly forward and internally rotated, right? So think you have a client like that with high femoral anteversion. So that means that femur is already rotated forward relative to the knee. And that person may naturally stand toe in, right? Just to balance themselves out. And you can't cue that away, right? You can't cue that away permanently. They maybe listen to you for a couple of reps, but as they go outside, they will still stand how they stand. So, and the reason is because it's a structural position of the femur. Or, for example, if the neck shaft, right? If the neck shaft angle is more vertical, like we discussed before, which is called coxa valga, the abductor lever or the abductor moment arm will be shorter. The glute med will have to generate much more force for the same stabilizing effect with the person who have like a normal angle, right? Or slightly bigger angle. So that's a leverage kind of issue. It's not a muscle weakness. So the main thing to take away from here is that our geometry matters and the muscles operate within the geometry. Now, there are bone shapes as well, and it's not just aesthetics. They reflect the mechanical function of the bone itself. And I thought it would be nice to have this lecture here, although it's probably general anatomy. But I tried to link it to the hips itself. So, for example, we have the bones in our body that's called long bones, and that's typical bone is a femur, and they're levers, right? So they basically add you can add weight, reduce weight. The elongated shaft, sorry, this is the bone shaft. Yes, it's quite long, and because of that, it increases torque production, right? So how much load will this bone, in this case femur, will have on the pelvis, right? And this torque production will obviously depend on the distance, right? How it will transmit force will depend whether your legs straight, whether your legs bend, right? So this is kind of how levers work. So they provide this kind of long bones. They provide large surface areas at the ends of joint articulations. So they usually have like a large kind of this head of the bone, and the muscles attachment along the shaft allow force amplification, right? So your quadriceps will attach kind of along that bone. Then there are flat bone, and they're like sternum. There's some parts of the ilium that can considered a flat bone. The ilium is an innominate bone, as you may remember, right? So there's like no name kind of bone. Um, but some parts of it can be described as flat bones. So these flat bones, or like in this case, we have the mandibular, like the bone in the top, and this bones disperse a force and provide kind of wide surface for muscle attachments. And for example, in our case of the pelvis, I mentioned in a previous lecture, wide ilium gives exactly that. It gives more area, right? More space for glutes, for attachment of the glutes, for like distribution of the force. So that's kind of the flat bones role. Then we have irregular bones, and our vertebrae also kind of fall into that category of irregular bones, and they're shaped to protect neural structures, right? Like your vertebral column is shaped to protect, is shaped specifically to protect the spinal cord. And they also allow kind of motion like everywhere, right? So they can be irregular to promote motion maybe one way or another way, or just be kind of all around us. So their shape resists certain forces while permitting other forces there. And the short bones, this is the hand, right? So, and then the wrist, and I think, yeah. And then there's a lot of like small bones in your wrist. I think there's 16 or 18, don't remember exactly. So short bones are designed for stability with very little movement, and they absorb compressive loads and distribute force across small areas. Then there is a sesamoid bone like patella, and they act as pulleys, right? So they increase a lever of a tendon or a moment arm. Get used to this term. It is used a lot in the research, called moment arm, not always called the lever. So they increase the moment arm of a tendon, improving its mechanical efficiency. So, for example, the patella increases the leverage of the quadriceps. Okay. Let's bring it back to the hip now. So femur is a long bone. Its shaft length amplifies force, but also magnifies joint reaction forces, right? Meaning how much force is going to the our hip through our hip joint, right? The ilium behaves like a flat bone, or some parts of it behave like a flat bone, and it spreads load, hosts large muscle groups like glutes, for example. The sacrum is an irregular bone. It's shaped for load transmission and neural protection as well, because there's some nerves that are there, and these shapes dictate just mechanical behavior even before you think about muscles, right? Before the muscles kind of enter a chat. Okay. It's while I'm saying like, oh, the bones, the structures are important, I don't want to make an impression that I don't care about the muscles. Muscles still do a lot, right? They can improve control, they can improve load tolerance, they can improve coordination of the movement, timing of the movement, quality of the movement, but they don't what they don't do, they don't rewrite the anatomy of the human, the geometry of the human. So understanding geometry in a studio setting is an observational skill, and the more you look, the better you get. So you can try and view your clients maybe from this angle. When you're working with them, you can just ask yourself a question: what is their geometry? So now we studied the pelvis and the hips, you kind of can have a look and you're like, okay, what is their geometry? Interesting. Where is their acetabulum sits? They may not even know, and they not always need to, right? They may have no clue. So, how is their pelvis shaped? Is it wider? Is it narrower? Is it longer? Is it shorter? What's the level? We're not all asymmetrical, right? Does the level different of your ASIS? And then how deep is the femur sits? Is it a bit forward? Is it a bit out? Is it a bit kind of anterior? And so on. So I think that's quite an interesting observations that can be done in a studio, especially when you see different clients often, not the same, like not three same people. And these observations eventually will help you just in will help you find better cues that work exactly for that person, and also will set realistic boundaries with repertoire that you can expect from a human to do, and also you will be able to select exercises better for them. I added a really a slide for like a quick tangent or comparison of hip joint and shoulder joint. They both are ball and socket joint, and we know that, right? And very often the shoulder compare is compared to the hip, and it's true, right? It makes total sense because they are ball and socket joint, and they kind of have similarities and similar structures, right? So, but I wanted to see you to have a look at the photo like itself to see the differences. Here we're looking at the posterior view, like right. No, sorry, we're looking at the anterior view. So here's the clavicle. Yeah, anterior view of the right shoulder. And you can see the socket here, and you can see the humerus head here. And already, like with the naked eye, right? And then we're looking at the left anterior view of the pelvis, and you can see the head of the femur here and the socket. And you can see the difference. First of all, I will I will name it for you, right? This socket is really shallow, and this socket is quite deep. You see how it's a cup, right? It's a vinegar cup, remember? You can't even see the depth, right? It's probably somewhere around here. So it goes this way if I trace it. Yeah. So this head sits deep into the socket, where the shoulder doesn't even sit in there, right? It kind of glides over it. Yeah. So you probably will assume that it's a smaller structure, the shoulder. It's also maybe a little bit more vulnerable for dislocations, for fractures, for all this kind of things, because it has quite a lot of mobility. It has more mobility than in the hip, right? So the circumduction is bigger, for example, and pretty much anything, right? External internal rotation is much. The ranges of the joint are much bigger, and they're bigger because the socket is shallower. It doesn't suction the humerus head in, where here it does. So if you look at the X-rays, you can see how deep it is, and you can see it's obviously there are like ligaments and tendons, and there's a rotator cuff structure here, so it's not just hovering, floating in space. But I think it's quite obvious, right, how much smaller the socket is and how much shallower comparing to the head of the humerus, where here acetabulum is designed to fit the head of a femur right in. This one just sits on top of it. Yeah, so just two ball and socket joints and their distinction. And there's quite cool research that I attach here. Have a read. So this is a slide that just shows you a little bit deeper in this particular photo, a bit more, right? So you have the ligament here off the head of the femur, that which wasn't visible in the other slides, and it attaches deep inside the hip socket. And then we're going to go through some of the representations, what's called cam and pincer impingement and the mix impingement in a bit. And I just wanted to probably bring your attention to the research and to how we now perceive and think about the hip socket and the hip joint. For a very long time, the dominant view of the hip, especially like in orthopedics and biomechanics field, was quite simple. The hip is a stable ball and socket joint. The cartilage is considered a cushioning passive material, and degeneration was framed as wear and tear. How many times, just be honest, did you tell your clients, not just wear and tear probably, and how many times you heard it in your life, oh, like I have wear and tear in my hip? So load was, if you look at it at this angle, load was thought as it's a destructive mechanism, right? So the more load you have, the more wear and tear you have. That's kind of quite a linear correlation. More load, more wear and tear, cartilage wears out, you have kind of cartilage failure, and then you get osteoarthritis. That's kind of natural progression. And that model made sense, right? So if you think about the machines in an industrial setting, machines wear out, their bearings degrade. So it's the same with joints, right? Total sense. However, over the last few decades, that model changed quite significantly. And modern research now shows that cartilage is not just the passive padding, it's a living tissue. And what's called chronocrocyte, let me try it again, chondrocytes. And the chondrocytes are a special type of cells that are responsible for making the new cartilage. So these chondrocytes respond to load, to mechanical stimulation, which is load. So synovial, and then based on that, synovial fluid exchange depends on the cyclic compression. Cartilage thickness adapts to habitual loading patterns, right? Instead of wear and tear, like we used to say before, we now talk more about load adaptation, load tolerance, how important load is, that we need to load, we need impact, all this kind of things. So that's a massive shift, and it just happened in the past 20, 30 years. So load itself is not harmful, it's necessary, it's beneficial. And the problem is not the compression itself. So what's the problem then? It's more like maladaptive load in the structurally disadvantaged kind of situation over a long time, right? So if there is a structural disadvantage and you're applying a load there all the time during daily life, then yes, it's not a good load that we want to have. So load is different from load, right? So not every load is the same. Another major shift came from morphology research, and I'm gonna kind of discuss it in a bit more details. I have links on the next slide and on the previous slide. So before Gans, and Gans is a famous researcher still researchers, but in 2000s they did quite a lot of good research there in University of Bern, and in 2003 they proposed that femoroacetabular impingement as a mechanical contributor to early osteoarthritis. And many cases of hip degeneration were labeled as idiopathic. That means that there's no clear cause why this impingement happens, right? And this impingement kind of linked to early osteoarthritis. So we don't know why it happens. And Gann's work, as above other things, suggested that the subtle variation of the cam morphology or acetabular overcoverage could create repeated abnormal impact during some flexion and rotation of the joint. So, on a side note, while cam, which is you can see here, like cam impingement, you can see here, while cam is an issue with the ball, pincer is an impingement. A pincer impingement is an issue with the socket, and you can have a mix of both if you're quite unlucky. So you're like, okay, thanks. What's that for me? What does that mean for me? That just reframed the whole view on degeneration of the joint from kind of random degeneration to motion specific mechanical stress. But even then, that model was evolved since 2003, and later population studies showed that cam morphology is very common in asymptomatic individuals. You probably heard this many times before. A lot of things are very common and in asymptomatic individuals. You may have you may have some things, you may have no pain. So morphology increases risk, but it doesn't determine outcome. It doesn't mean that you will have a lot of pain. So that forced all these findings forced the field to integrate biology, inflammation, recovery, and systemic factors into consideration, into conversation. It's not just one thing, it's a whole kind of salad or soup of everything that affects why we get an injury, how we get an injury, and even then we may not know exactly why. Another evolution happened in our understanding of ligaments and joint stability. And for example, structures like the ligament teres, round ligament, it's not in the picture, but it's kind of inside there, kind of inside the hip. So, for example, it's used that ligament, the round ligament that's inside, it used to be considered as like non-functional. It's just there for whatever reason. However, now we know that it contains a mechanoreceptors, which is like a sense organ or a cell that responds to mechanical stimuli such as touch or sound, for example, and that may contribute to proprioception, to deep flexion stability, to a lot of other things. So these mechanoreceptors are deep inside into your hip joint. So it means that it just shows us that the hip is not just like a structure and it's like a machine and then the bearings wear out. It just means that the hip is more than that. It's a sensory organ, right? So after that, we have broader view from the research on the hip structure and on the hip pathologies. There is such thing as called Punjabi stability model. Punjabi was talking about the spine, right? But it's also his research was also influenced how we look at the joints generally, right? Not only the hip. So the his research kind of described the passive structures, active muscle system, and neural control. They all interact together. The hip is not stabilized just by bone alone, and not by muscle alone, and not by ligament alone. It's stabilized by all these things together. So finally, when we got imaging, imaging technology evolving, we can also now perform MRI, CT scans, and then we can research more into the labrum tears, cartilage defects, and subtle shape differences that were invisible before. So with all this research advancement, we introduced new challenges. We now see many structural abnormalities in people without any pain. And that forces us, allied health professionals and health professionals, to recognize that structure doesn't equal symptoms. And it's been kind of shouted out from the roofs. day in again, like about the pain and all this, but I still see that you like, no, we all like, yeah, 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 okay, that makes sense. But in my studio, I can prevent them from getting worse if I focus on their alignment, right? So yes, but there is no but. The modern view of the hip, that it's no longer that it's the hinge that wears out. We more look at it as a structurally viable, biologically adaptive sensory motor system that tolerates high load under most conditions and degenerates when multiple risk factors align, not one. So it's not just important for academia, it just changes how we speak to clients, what we tell them about movement, and it's also affects how we interpret the limitations that are presented, the range limits that the clients present. So also probably if you see an MRI and what's written in the doctor's report, you can be a little bit more kind of calm, right? About if there are like a lot of things found and the client does not present any pain, or they present a different pain from what they found. So you can be like, yeah, that happens. You can have some structural deviations or deformations, but you may not have any symptoms, and that's totally fine. So probably to take away from this whole lecture is that if we teach the hips as just a static mechanical object, we use outdated science in today's world. So we want to teach the hips, and we want to teach our clients as well, that the hip is an adaptive biological system. And it's important as a professional to understand that, because it helps your reasoning. All right, you guys, that's it from me for today. The only side note that I want to let you know, as a kind of homework, I have a final slide, and you can download the slides in your course content. And then you can click this link. It's unclickable for me, but I would like you to see an Instagram post. And the reason for Instagram post, I couldn't find enough images to show you the differences between our structure. And I thought this Instagram post showed just perfectly on real humans when the physio kind of does internal and external rotation. I highly recommend you to have a look. I don't know the person who did the Instagram. I have nothing to deal with, but I just thought it's an amazing Instagram post that kind of has a carousel slides that explains how different we are, how different the position, and how it affects our range of squatting, of just external or internal rotation. Let me know what you think about the lecture, and I will see you in the next one. Bye.